The ASH Research Collaborative is a separate 501c3 organization that ASH established in 2018, houses a few large projects, including the ASH Research Collaborative Data Hub and the Clinical Trials Network, which is primarily focused on sickle cell disease. Given the recognition of the COVID-19 pandemic and the potential impact on patients with underlying cancers, and in particular patients with underlying hematologic malignancies, the ASH Research Collaborative in the early days of the pandemic back in the spring opted to start a voluntary data contribution registry so we could better understand the potential risks of our patients who had acquired the COVID-19 infection. So this was launched back in the early days of the pandemic, and we began to obtain data from sites around the country and indeed around the world. Data were brought in through a secure web-based portal, stored in a secure, de-identified manner. We obtained central IRB review and exemption for this, and made procedures GDPR compliant to allow for centers in different countries to contribute data as well. Since that time, we ended up bringing in a number of patient-level data summaries of individuals with various underlying hematologic malignancies who acquired COVID-19 infection. We obtained information about baseline patient characteristics, including sociodemographics, baseline characteristics of the underlying hematologic disease, including disease characterization, current level of disease control, various recent disease-directed therapies received, underlying prognosis from the perspective of the underlying hematologic malignancy, irrespective of COVID-19 infection. We also obtained information for each patient around information related to the COVID-19 infection itself, including symptoms, duration of symptoms, and any COVID-19 directed therapies that were received, severity of the COVID-19 infection, including whether or not it was outpatient level severity or hospitalization or ICU level severity. We obtained information about whether or not intensive treatment was given or deferred, and we also obtained information about ultimate outcome, including recovery or mortality. So with that as background, we intended to characterize our early response with this disease registry. We concurrently published our results in Blood Advances at the time of the ASH annual meeting presentation. The written publication included data on the first 250 patients, and the ASH annual meeting presentation included data on approximately 650 patients. And subsequent to that, we've had some additional data contribution. And now, if you actually go to our online data summaries at www.ashrc.org, you'll see that we have about 750 patients with underlying malignant hematologic diseases that are now part of the registry. Our main findings were that patients with underlying hematologic malignancies are a medically vulnerable population when it comes to COVID-19 infection. In our written Blood Advances publication, we reported a 28% mortality of the first 250 patients. By the time we presented our findings at the ASH annual meeting with now 650 patients or so of data, we reported a 20% mortality. It's possible that that mortality figure had improved over time, though without the exact dates of COVID-19 diagnosis, that was hard to say definitively. We couldn't acquire the exact dates because of the de-identified nature of the registry, but it's possible that what we saw did reflect improvements over time that mirrored improvements in outcomes in the general population. We also reported that for those patients who had at least hospitalization level severity, the mortality was approximately 33%. We also identified some factors that appear to be associated with particular adverse outcomes, and these included, importantly, age, underlying comorbidity, underlying status of the hematologic disease, pre-COVID-19 prognosis, among other potential factors. And lastly, I should mention that we identified that there were several patients who actually deferred intensive level care, and as might be expected, the mortality among that particular population was quite high. On the flip side, we also found that there were some patients who did opt to receive intensive care for their COVID-19 infection, and sometimes despite the presence of accompanying other adverse risk factors, those patients made full recoveries from their infection as well. So in summary, I think we found that we had a medically vulnerable population, but that the risks were differentially distributed with some characteristic risk factors that we were able to identify in our initial data analysis. I was very gratified that we were able to launch this registry quickly, that we obtained a lot of enthusiasm, interest, and engagement from hematologists around the world, and hopefully that we're providing value back to hematologists, again, through the online data summaries, which we try to update on a daily or even every other day basis sometimes. I think with that having been said, we do look towards a future in which we'll be building out our other signature data collection platforms, such as the ASH Research Collaborative Data Hub. These other platforms actually include site-level direct EHR data integration. We'll be building in COVID-19 and other diagnoses into that data collection platform, and we hope that we'll be well positioned to provide broader characterization of hematologic populations, their risk for COVID-19 severity and outcomes, and we'll have a true denominator-based look to answer these questions in even more detail moving forward.